The iwCLL guidelines needed to be updated because there was so much innovation. I think it's important then to realize, do we have to change the guidelines because so much new things are going on? And actually the bottom line is most of the things can remain as they were, but there are some exceptions. Number one, we will carve out the relevant prognostic factors, and again, all the novel genomic markers and so on are not mature in terms of clinical application yet, so that we have a couple of important markers now confirmed several times by clinical trials, and we will list them. They are IgVH mutational status, deletion 17p or p53 mutation, beta-2 microglobin are relevant prognostic factors. Second, with the novel inhibitors, they are continuously given. So we see more and more continued therapies, sometimes for years. And it was not clear how we could assess responses in these patients because at former times we needed to stop therapy and then go 2 to 3 months later assess the response. That's not possible under continued treatment. So we had to clarify the guidelines to avoid confusion, both in practice, but more importantly in this case for the regulators, because they sometimes requested investigators to stop therapy to assess the response, which is clinically not meaningful, it's nonsense. So this is a very important clarification. And maybe finally MRD assessment, I think, will gain more importance, because now with all the potent inhibitors, we will aim to design therapies that are ended at some point, and then they will be finished with MRD negative results. So as soon as the disease has disappeared by MRD assessment, therapies will be stopped. And that's a new emphasis, I would say, that the guidelines put on this marker, MRD assessment.